So it is a privilege to have you here, sir. And over to you, sir. Thank you.
Thanks a lot, Dr. Sonia, for those kind word of introduction and for this invitation to discuss on this very, very important aspect of physiology, which is endocrinology. And we all will understand that of all the branches which are probably related to clinical medicine, the one which is the most linked to physiology is actually endocrinology. If one understands the endocrine physiology well, it will become much easier for the person to think about in terms of overall outcome, in terms of overall responsiveness and assessment. And that's why it's very, very interesting and very important that at this stage, all of you learn about the basics of endocrine physiology, because this is going to help you a lot in terms of subsequent practice. What I'm trying to do today is to talk a bit about physiology, but I'm also going to take you through about some of those clinical aspects which will try to make it more interesting, so that you get more engaged into this aspect. And it's not just that we're talking about theoretical aspects, we're also talking about its application in clinical practice. Endocrinology is one branch which is considered to be fascinating in terms of clinical practice, which affects head to toe each part of the body. Very importantly, unlike many other cases, you will not see the hormones. So you will see some cases, you will see the neurological features, some cases you can examine for cardiovascular features. Usually it is the biochemical and physiological interaction which really determines endocrinology. And that's why understanding physiology is very important. So what we'll do, we'll start off basically with what really is hormones and endocrinology. We'll then move forward about how the glands are formed, how they produce their hormones, how the hormones work, and what are the changes which happen in the fetal period, and because that is very, very relevant from that perspective. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of information and many videos are available on these physiological aspects of different parts of endocrinology. Now, when we talk about hormones, the most important thing to remember is that hormones are the most important communicators of the body. They're taking communications from one part to the other. So they are like the postmen which are there, which are being deployed by one organ to send the message to the other. The key aspects of hormones are that they act at a site which is distinct from the site of origin. Now, if you compare two very important messengers or communicators, they are neurotransmitters and hormones. And often you will find that there is an overlap. That's why we talk about neuroendocrine system. Neurotransmitters are working just right next door. So they're your local courier person who's going from one place to the other, while hormones are your long distance couriers going from one country to the other. They may go from the pituitary to the femur. So they will go a long way across in that perspective. So they act at sites which are distant from their site of origin. Very importantly, the amount of hormones which are there in the body is very limited. So if you take entire hormone in the blood which is circulating in an adult, it will be equivalent to around 5 grams. It will be just like 1 spoon. But this 1 spoon is controlling the entire physiology, entire salt status, glucose status, growth, reproduction, puberty. So this is a very, very small amount of content doing the maximum effect. And this is something which is very, very interesting as far as endocrinology is concerned. Now, when we talk about endocrine system, classically, we talk about they being regulating the major parts of the body. The key aspects include calcium, bone, volume and salt, glucose. Now, these are very, very important. Plus, they also regulate long-term. So there are short-term controls which regulate your calcium, your volume and glucose, without which an individual will die. But there could also be implications in terms of long-term effects on bone, growth, puberty and reproduction, as well as temperature. So hormones are not only involved in acute regulation, they are also involved in chronic regulation, and that makes them very, very important from a clinical perspective. So they are very crucial. They link two very important processes. How much is your energy status, that is nutrition, and how much are you going to use it to build up your bones, to build up your height, to build up your reproduction. That crucial link comes from these hormones. And there is, of course, an interaction between physiology and pathology, which is what we'll be discussing subsequently. Now, essentially, hormones belong to a chemical messenger group of compounds which act via 3 major pathways. One, of course, is the endocrine pathway, in which the gland releases the chemical into the blood. It goes to a distant site and acts on a distant form. This is the classic endocrine or a hormonal response. The second response may happen is that it is secreted and it is acting like a nearby location, and this is known as the paracrine effect. And finally, the signals may actually act on the same cells on which it is originating, and this is known as the autocrine effect. So the same chemical can act distantly, like a very long distant courier. It may happen like just your person who is delivering the thing very close by, or it may itself regulate you. So the same chemical can act in an endocrine manner and become a hormone, in a paracrine manner to become a local regulator, and an autocrine manner to regulate overall secretion. So the distinction between all three is blurred. You don't say that this is endocrine, this is paracrine. It is where the hormone is acting will make it in that perspective. So growth hormone can go to a distant part and act on the bone from the pituitary. There it will be a hormone. It may act around the cells within the pituitary area on the other secretory cells. This will become paracrine. It may also inhibit the secretion of growth hormone subsequently, and this becomes autocrine. So this three is very, very important to understand in terms of clinical perspective. Now, when we talk about an endocrine system, we are talking about a substance like growth hormone, which is secreted via the gland. So when we say endocrine, it means they are directly secreting into the blood, as against exocrine, in which there is a duct and the duct takes it to the blood. So this is a major difference, and that's why there are two major types of glands in the body. The exocrine glands, like the pancreatic, the digestive part of it, a lot of these areas will have a duct, and this duct will take their secretion. These are ductless glands which directly put into the bloodstream. So now this will then go to the site of their particular action, and every site will have an individual receptor on which these hormones will go and act. And from there, you have a combination. So endocrine gland and a target organ, and they will interact and cause particular effect. Now, importantly, the target organ can also send their signals back towards the particular gland to say, okay, now we have had enough, you can shut it down. So there could be an overlap between what is an endocrine gland and what is a target gland. So here, if you see, pituitary is controlling growth plate is also controlling pituitary. So which is an endocrine gland? This is an interesting and a confusing story in that regards. So classically, we talk about systems which have been long established, including pituitary, thyroid, pancreas, gonads, parathyroid, and adrenal, which control the entire body. But now, if we use the simple idea of hormone being a substance produced at one site, going to another site and acting, lot of other areas become potential. So the brain produces a substance known as brain natriuretic peptide, which causes loss of sodium. So do we call brain an endocrine organ? The bones produce osteocalcin, which has the effect on insulin sensitivity. Do we call bone an endocrine organ? The adipocytes are definitely an endocrine organ because they produce a lot of these signals like leptin, which control energy metabolism, growth, bone, and puberty. We have got heart, which produces, if its volume becomes too much, it will push atrial natriuretic peptide and say, okay, I want the sodium to go off. And therefore, heart is also an endocrine organ. Intestines, we all know, produce incretins. As soon as you get your carbohydrate, it produces this incretin, telling the pancreas secrete insulin. So they again can be an endocrine organ, as well as kidney, we know, the renin system. So it's not just that we have got this focused approach with regards to this is an endocrine system. Any gland which produces a particular hormone and which goes to a distant part to act can be an endocrine system, and we need to be open about that. But I'll be focusing mainly on the classical systems today for the purpose of discussion. So now if you look at a particular hormone, it has to be secreted, produced and secreted by the gland. It has to go to the blood, from where they will then go on to add to a particular binding protein, which will carry it forward to target areas of action. And from there, they can either be activated or inactivated, and this will result in an end result in terms of hormone action. So there is a process in which a particular hormone acts. And each and every process is important from a physiological as well as pathological perspective. And that's why we'll go one by one in terms of these aspects, assessment and the fact. Now, very importantly, we also need to know that the gland knows when to shut down. If you're producing too much growth hormone, the growth will continue. So there has to be a way the gland senses it so that this effect is taken off. So this really provides the information about when to stop, and that becomes important from that perspective. So this is how the hormones interact, and this becomes important from a endocrine and a clinical perspective. So now we know that the hormones have multiple effects in different parts of the body. There are two important aspects of hormone functions which needs to be understood. The same hormone can do multiple things, and this is known as pleiotrophy. The classical example is thyroid, which can, deficiency of which will decrease your bone strength, will have an effect on the brains, will have the effect on the heart, the pumping will become less, the heat will become less, the person will become cold, there would be decreased growth as well as decreased gastric motility. So hypothyroidism, which is the most common form of endocrine dysfunction that you will see in your practice, will result in lethargy, decreased cardiac function, sometimes cardiac failure, cold intolerance, growth failure, constipation, and reduced bone strength. So one particular organ is affecting so much, so you need to be aware that there could be a wide variety of clinical features. The second very important thing is that in places where it is very, very important for body, there is always a redundancy. So we all know that the body is really scared of glucose level going down. If glucose goes down, the brain will have a huge problem. That's why the body has got 4 particular hormonal systems which are regulating this glucose decrease. There is only one which causes a decrease, which is insulin. But there are 4: epinephrine, glucagon, cortisol, and growth hormone, which are pushing the glucose up. What it means is that if you have just deficiency of growth hormone, just deficiency of cortisol, you are not going to develop hypoglycemia. The body is evolved to prevent that particular individual from going into hypoglycemia. And this is very important, and this is known as redundancy. So when you're evaluating a hormone system, think about one hormone can have multiple effect, and multiple hormones can have one effect. And this is why when you have hypoglycemia, you have to think of multiple hormones. You can't just think of one particular hormone in that particular regard. So now we've discussed about how these hormones are being produced and how they are going to act. Now we need to know that there are various functions that the hormones do. And that's why they have different structures. Like if you have an army, you will have people who will specifically go for a very rapid combat. There'll be one who will be good at maybe the particular tanks they will work on. Some would be working more in terms of deep retreat. So the same way, the body has developed multiple classes of hormones to do different functions. Now, if you classically talk about endocrine functions, there are 2 types of functions. One is just rapid response. Rapid response is required for things like when you are dying because of low glucose, you're dying because of very low blood pressure, your sodium is very low, your temperature is very low, body cannot wait for ages. So you need a quick, immediate response, a substance which is either produced immediately, released immediately, acts immediately. On the other hand, you have got processes like growth, like puberty, reproduction, bone health, which are slow processes, which body can wait. So for there, you need substances which are, there is no urgency. You can produce them slowly, they can work slowly, but they need to work in a concerted action for a long duration. So they have to have a long half-life. So if you divide between acute response versus a chronic response, the acute responders, the first responders have to be fast, quick to produce, quick to act, quick to go. If you allow them to keep on working, that will be a problem. On the other hand, you will have marathon runners like those who are controlling your growth, your reproduction. They will be slow to produce, slow to act, but they will keep on acting. So therefore, you broadly need to have 2 different types of hormones. And we'll talk about that, how steroids, which are the slow players, are those who will work for the test match, while those who are working very rapidly like small peptides will be more like 20-20. So this is the main difference between the different hormone systems which are there. So peptide hormones are produced via the glands. They are usually stored within the gland. So large peptide hormones take long time to produce, but the body will keep them stored. So if you have some battle going on, you can't wait to produce a new particular aircraft. You can't immediately build a new aircraft. So you have to have a squadron of aircraft. Similarly, if you want your body to produce insulin, you can't produce insulin, which is the big molecule, immediately. It has to be stored. So these molecules are stored. They are usually water soluble because of being peptide. Now, if they are water soluble, they can go quickly through the blood. They can run through the blood because they don't need a carrier. They can go immediately. They will go to the particular site. They are not dependent upon binding proteins. But the problem is that if binding proteins are not there, they will be immediately degraded. And therefore, they have a short half-life, which is an advantage. Quick to produce, quick to go off. And then they will go immediately to their site of action. But because they are peptides, they cannot enter the cell. So they need a receptor which is outside the cell. And this is very, very crucial for peptides, that they will act on an extracellular receptor. So to summarize, peptides are usually produced immediately or stored and released immediately in response to a particular stress. They will go through the blood very quickly. They don't need binding proteins to bind, but they will be degraded quickly. They will act on extracellular receptor in that regards. The classic example of peptides include parathyroid hormone, growth hormone, insulin. A lot of these hormones will be peptides. Now, very importantly, there is always a structural homology, which may be there in different peptide hormones, which means that one hormone can act on the other's place. And this has clinical significance in that regards. Now, if you look at these group of hormones, one is TSH, which is basically there to control thyroid. The other are LH, FSH, HCG, all controlling ovarian functions in a female. So they are basically for reproduction. But what happens is TSH looks like FSH. So if the body has got a huge amount of high TSH, which happens in hypothyroidism, it is going to act on the FSH receptor. So FSH receptor is very good in saying that, okay, if FSH comes, I'll bind. But if you have got 10,000 times another compound which is looking similar, some of it will bind, and that is going to cause a lot of issues. Ovaries will become hyperstimulated. You will have ovarian cysts. And this overlap is very, very important to understand and forms the basis of both ovarian cysts in girls and large testes in boy, because FSH causes enlargement of testes. So we need to understand that although there is a specific action, there is also overlap which may happen in that regard. Similarly, HCG, as discussed, is similar. It is going to behave like TSH and cause hyperthyroidism in pregnancy. So pregnant women need to have more energy. They need to have a higher metabolism, and that's why their TSH goes down. This HCG, which comes from the placenta, acts on the TSH receptor. So there is an overlap which we need to be always wary about in that regards, and it will cause other aspects as well. So although one hormone has one main action, it can also have side actions, and it can act on other pathways as well, which we need to understand in that regards. This is the example I was talking about, a 7-year-old girl who was really short, but very early puberty. Now, most of us will think that if somebody is early puberty, they will be ovaries are producing a lot of hormones, which is true in this case. The ovaries had a large cyst, but this was not because of a reproductive problem. It was because of a hypothyroidism. So because of the thyroid being low, she had a very high TSH, body was trying to compensate. That produced this ovarian cyst, and this is the overlap causing what is a very interesting endocrine system of von Wieck-Grumbach syndrome of ovarian cyst and precocious puberty. So what I'm trying to say is that all this physiology is very, very relevant when you actually apply them in terms of clinical practice in that regards. Now, as against peptides, the second group of hormones are steroids. And these steroids are slow. They don't need to work. They are not for 2020. They are like long haul player. They're like Rahul Dravid. So they will basically be fat soluble. They will go into the blood. But because they are fat soluble, they are not in a hurry. So they can be slowly going into the blood circulation, and they would need special carriers. So they are like VIPs. They need a particular taxi to carry them forward, a chaperone protein. So a binding protein will be there, which will take them towards their destination. So they need a binding protein to bind. Now, if you're surrounded by a binding protein, the metabolism will not happen. So they will have a longer half-life. So this is another important difference. They will not be inactivated by the plasma enzymes. They will then have a long half-life, and then because they are lipid soluble, they will cross through the membrane immediately, and they can act inside the cell. And this is very important. They will have a intracellular receptor. So as against peptides, which are quick to produce, quick to act, quick to go, not requiring binding and extracellular receptors, steroid hormones are slow to produce, slow to traverse, require binding protein, long to act, have a long half-life, and have an intracellular receptor. So if you understand why the body needs which hormone, you can understand which group of hormones will control that in that regards. Now, there are third group of hormones which are immediate. These are like absolutely pinch hitters. You need them just if you want 20 runs in 1 over, you will send them. The classic example of that is would be epinephrine. So this is like an immediate regulation. You want to immediately either fight or fright. This is the response you want, and that response comes from amino derivatives, which are basically neurotransmitters in a classical sense, but they are also hormones. These are water soluble. They will not be binding to the binding proteins, and they will be degraded immediately because you don't want them to create a havoc. If your epinephrine is permanently high, the body will be in a stress situation. They will have an ultra short half-life, immediately act on the membrane receptor, as well as act on the intracellular receptor. So they have a dual action, but they are just for that moment. They are not going to be there for even minutes. They are there for a few seconds. You are going to run. If you have a lion in front of you, you can't wait and watch and think. You produce epinephrine and run away from that place. And then your epinephrine goes down. So they are the third class, not very significant from an endocrine pathology perspective, but very important from a life physiology perspective in that setting. Now, if you look at hormone classes, we can think of peptide hormones, which I said are the rapid acting hormones. They include small hormones which come from the hypothalamus. So these are like 3 to 10 peptides. They are going to control the pituitary. Then you have got complex hormones like growth hormone and prolactin, which are big. Their role is also big. They are causing growth. They are causing lactation. Without that, there'll be a huge problem. And then you have multiple chains, particularly like TSH, LH, FSH, insulin. So there are different types of peptides, but they all will be either produced immediately or they will be released immediately. They will have a short half-life and will act on extracellular receptor. This is common to all of them. The steroid hormones include most which control your blood pressure, glucose, reproduction, like cortisol, aldosterone, testosterone. They will be produced slowly, work slowly, long half-life, intracellular receptor. And finally, amine derivatives, typically epinephrine, norepinephrine, which are very, very pinch hitters, which are there only for less than a minute, and they will act immediately and work from that perspective. So these are the 3 different classes of hormones in that perspective. So if we compare, peptides are usually large. They will not be binding. They will act on membrane receptors, metabolize rapidly, and will have a short half-life. Steroids will have a medium size. They will have a high protein binding. Usually they will act inside the cell, slow metabolism, long action, and amine derivatives, as I said, are rapid acting. So they will go and come and go immediately in that regards. So we have talked a lot in terms of what are the types of hormones. The next step, of course, is how are they produced. So as I said, there are 2 response patterns, the rapid response patterns and the slow response pattern. The rapid is responsible for controlling things like calcium, because the child will or the person will die if your calcium becomes low, your glucose becomes low, or your volume becomes low. Slow, as I discussed, is more for bone formation, growth, and reproduction and puberty. Now, hormones which are there for rapid actions will basically be already there. You will already have them ready to dispatch as soon as something happens. Those commandos will go immediately. while these will be produced as and when required. So if you are talking about, let's say, a company like Amazon, if a product is being sold in millions, they will have a lot of it in stock and they will immediately send it. But if somebody is ordering a book maybe once in a year, they will produce as required. So this is the difference between the rapid and the slow action in that setting. Now, the classic example of synthesis is that of ACTH, which is a very, very important regulator of adrenal functions. It is produced by the pituitary. It is the adrenocorticotropin hormone. Now, most of these hormones are actually produced as a prohormone. So when we talk about ACTH, it is not just ACTH. It has got 4 different types of hormones which are also there in the big particular gene, the exome that you're talking about. So from there, it produces MSH, which causes pigmentation, increases appetite, produces ACTH, which regulates the adrenal, and produces endorphin, which controls stress and pain. So if you have anybody who has got low level of adrenal hormones, that is cortisol deficiency, the body will produce a lot of ACTH, but it will also produce a lot of MSH. Now, what will that high MSH do, Dr. Manoj?
High MSH
will cause more of pigmentation. So if you have a problem in adrenal synthesis, you will have more pigmentation, and therefore if you have low cortisol in a dark individual who is getting pigmented, you know your ACTH is high, and you know that it is basically because of an adrenal problem. So this gives again an important clue in that perspective, and this is a slow synthesis and storage. Similarly, because you are also regulating appetite, so if you have a problem in this particular ACTH, you can also have a problem in the appetite regulation, and you can have children who come to you with severe obesity, who have got lethargy and weakness because their adrenal hormones are low, and they have a deficiency in the convertase enzyme which converts it into multiple hormones. So when you talk about hormone synthesis, know which enzyme produces this hormone, which are the other hormones which are produced along with that, and that will give you the clue of its manifestations and other features in that regards. Now, the second step which really regulates the overall hormone action is the release. So hormones are regulated either at the level of synthesis or at the level of release. Now, quick hormones, as I said, which control calcium, like parathyroid hormone, cortisol, like ACTH, or insulin, which regulates glucose, will be regulated at the level of release. Now, this release can be pulsatile. Now, most hormones have a pulsatile secretion. So do not rely on a single hormone level, especially for most of these peptides, because if you have a single hormone, you may have done it at the lowest level or at the highest level. There comes the concept of dynamic tests in endocrinology. When you talk about dynamic tests, it means that if your levels are high, you suppress it. If your levels are low, you stimulate it. So if you're looking for growth hormone deficiency, do not do a basal growth hormone. You give something, some drug, some exercise, some sleep, whatever, which increases the growth hormone level. If you're looking for cortisol excess, you suppress it using dexamethasone. So when you talk about endocrinology, the very important concept is dynamic testing. It's not a static. You just don't do single test. You do that, but when you want to confirm, you have to do a dynamic test because of this pulsatile secretion. There is also a change which happens with daytime. So your cortisol levels, for example, would have a different level. They will be highest in the morning because that's the time you want supposed to be active, and will be lowest at midnight when you're sleeping. So this tells you when to do the particular test, and therefore diurnal rhythm is very, very important. If you are looking for somebody whose cortisol is low, the best time to do would be in the morning, because that time it should be really high. If you're looking at somebody whose cortisol is high, do it at night, because that time it is the lowest. So looking at this diurnal rhythm is also important. There is also a variation with menstrual cycle, of course, very important for reproductive hormones, and variation with seasons, especially for vitamin D, which you need to be aware of. So when you're looking at ordering a particular endocrine test, this physiology will tell you when to order, what particular time of the period to order, what time of the day to order, and whether go for a dynamic test or a particular test which may be a static test in that regards, and that really gives you a particular thing. Now, as I said, many of these hormones are stored in the gland. One gland which has got the maximum storage capacity is the thyroid gland. It stores for 2 months because they never know when the iodine will become less and I can't be able to produce that. Now, what is the problem of storing for 2 months, Dr. Naveen? If your gland is damaged, what will happen?
It will release all the hormones.
So because your store is for 2 months, if the gland is damaged because of any reason, you will have sudden increase in hormone levels. And this is very important for thyroid, which is known as thyroiditis. And this is a typical example we are giving of a 17-year-old girl who presented to us referred as high thyroid. So she was referred that thyroid is low, she had sweating, she had got more temperature, hands were shaking, and heart rate was high. Somebody thought that we should block her thyroid production because she's producing more thyroid, her thyroid hormone levels are high. But when we actually looked at the nuclear scan, what we found that the thyroid was not functioning at all. So what it meant was that there was something which damaged the thyroid gland, and because of this damage of the thyroid gland, all the hormones were released. So this is an important mechanism how many of these diseases can come to you, and you don't just need to go, okay, thyroid is high, let's block it. No, hold on. Look at whether it is actually producing more or whether it is being released. And this is how you can distinguish and identify, and this is important from a clinical perspective in that setting. The second most important regulated, and I would say one of the most regulated hormones in the body is insulin. Now, insulin is going to decrease your glucose. So if you have too much insulin, you will have hypoglycemia. So there are 4 systems which are regulating insulin release. First, of course, is how much glucose you have. If you have got more glucose, if you have got more fat, if you've got more amino acids, or in a nutshell, you've got more ATP in the cells, the body will say, I need insulin. And then there is a specific, very interesting potassium ATP channel, which actually senses the ATP level and then decides, okay, your ATP is low, no insulin, ATP is high, insulin comes into the picture. So if glucose, protein, or nutrients are high, you will produce insulin. Second major control comes from the neurological factor. So if the brain thinks you need more insulin, you will have the vagus stimulation which will produce. The third, of course, is endocrine, which is regulating the various hormones are regulating. And the fourth most important is what is known as the incretin pathway, which is basically a way in which the stomach tells the pancreas, or the duodenum tells the pancreas that, okay, now you should produce insulin. Now, if you think of, if you eat something, your blood glucose increases, then your insulin increases, there will be a many hour gap. Now, what this incretin, the beauty of incretin effect is that as soon as the food reaches duodenum, it immediately gives a signal to the pancreas, okay, blood sugar is going to rise, get ready, start secretion. So in a way, it's a very complex process, but it is regulated by immediate blood glucose, neurons, as well as the eating process, the incretin pathway, which we'll decide about in that perspective. Now, if this response is defective, there will of course be a problem. And this is a very, very interesting child, 2-month-old child. Now, what happened in this child was presented mainly with very high sugar levels. And it is the only treatment which was there maybe 15 years ago was insulin. Now, what happened in this case was that there was a problem in the potassium ATP channel. So now what the potassium ATP channel is doing in this child is saying that, okay, your energy level is very low. So never produce insulin. So even if the sugar is 600, the ATP is very high, but the potassium channel is saying, okay, no need sleep. We don't need any more insulin. So this defect in this particular child was because of this potassium ATP channel. And if you give an old age drug, which is used in adults, glibenclamide or Dionel, which has been used for 50 years, when researchers found that if you use this drug, this potassium ATP channel suddenly wakes up. So this basically is a way in which this child, who was not even responding to insulin, responds dramatically to an oral drug. So if you understand the physiology, you understand the pathology. We know that potassium ATP channel controls insulin release. We know that in this child, the potassium ATP channel is sleeping. So now it's very easy how to wake it up. And we found very simple, if you give glibenclamide, it will respond. So this has changed the life of these rare conditions, but extremely good response that we are seeing in that perspective. So understanding physiology is very, very important from that perspective. So now we have talked about how a particular hormone is formed. Now it has to be taken to its site of action. And this transport process will require binding protein for some. So peptides don't need a binding protein, as I said. You will need binding proteins for steroids, definitely, which will carry it towards the cells. And amino derivatives also don't need a binding protein. So binding protein is important mainly for a steroid perspective, plus for rare peptides like IGF, which has got a lot of paracrine effect, and you don't want IGF to escape, and that's why you have got binding proteins for it in that regard. But it's basically steroids in that regards. Now, why are binding proteins important? Now, binding proteins are important because they are prolonging the half-life, they are increasing the action, but they are more important clinically from the perspective of testing for endocrine system. The classical example is the thyroid binding globulin. Now, most labs which assess thyroid functions do a total thyroid hormone. Now, out of the total thyroid hormone, only 0.3% is active, which is the free thyroid hormone. So if your thyroid binding globulin or albumin or the other binding globulin is high, your total hormone level will be high, but the actual free hormone level will be normal. On the opposite, if the levels are low, you will falsely label somebody as low thyroid when the actual there is no deficiency per se. So this understanding of binding globulin is important when you are assessing for a clinical perspective. And one thing which increases all of this is usually estrogen. So if there is a woman who is pregnant or who is on a estrogen progesterone pill, your thyroid functions will be absolutely haywire. You will have very high level of T3 and T4, which is total hormones. But because of this TBG being high, the free hormones are normal. So you will label that particular pregnant lady as hyperthyroidism if you just look at the total hormone, and you will start antithyroid. This could be lethal. So it's therefore important to understand how physiologically this binding globulin is increased via the estrogen, and this makes an important role in that regards, and testosterone decreases it in that perspective, and this is very important. So this is a typical case, a child who had features of low thyroid hormones, and clinically there were no features, but when we did the hormone levels, we found that the total T4 was low. Now somebody will say this is hypothyroidism, start treatment, but we know that it's the free hormone which is more important, which was normal. So when there is a doubt in hormonal practice, we always order for free hormones, and this becomes important to understand from this clinical perspective. Another very important binding globulin is the sex hormone binding globulin, which is responsible for modulating the action of estrogen and testosterone. So it is binding SHBG, and only the free hormone is going to act. If there is a problem in the sex hormone binding globulin, the free hormones will go up, and this will result in the effects of high testosterone in girls, causing hormonal changes like hair growth, period problem, and acne. So binding globulins and transporters are very, very important in this particular perspective to understand and highlight in that situation, and they become absolutely important from that regards. Now, once this particular hormone has reached its target site, it has to act. Now, this is very, very important because we are talking about changing the concentration, the relative concentration of a hormone to a tangible effect. So this is a chemical signal which is being then converted into a different signal. And therefore, hormone action is absolutely important to understand because this forms the basis of a number of disorders in which the receptors which are going to act, take the hormone up, are going to act more or act less. And this action becomes absolutely important in this regards. So hormone signaling, as we discussed, is that hormone goes through the blood where your concentration is there, and based upon your concentration, the effect is there. And this fine tuning or modulation is done via the hormone receptors. Now, when we talk about a cell membrane, this you would have already discussed in biochemistry. The cell membrane basically has got a lot of lipid in it. So it's got a phospholipid And in this, you have got extracellular and intracellular part. The extracellular part, which is touching the blood, is hydrophilic. So it is good for peptides. But the internal part of the membrane is hydrophobic. So your peptide hormones cannot cross through. Your steroids can easily cross through from that perspective. So peptide will be stopped by this particular membrane. They need to act on an extracellular receptor, a receptor which is outside the cell, and then they will produce action. Steroids can cross quickly through this because it's mainly a lipophilic hormone, and it will act on the nuclear receptor. And if you go to the nucleus, you're going to regulate mainly in terms of how the action of particular gene is going to be switched on or switched off. And finally, you can have some hormones like thyroid, which are given special preference, which have got a special vehicle which takes them inside, a transporter which takes them inside. So now if you talk about action of hormones, there are two typical types of hormones. One which act on the membrane, and they will cause immediate changes, act rapidly. So of course that has to be peptide. The second would be which go into the cell and cause changes in terms of overall genomic expression. So they will have a lag phase. So they will of course be steroids and thyroid in terms of long-term action. There is now an understanding that there is an overlap. Some of these steroid hormones can have some immediate effect through the membrane, and the peptide hormone can also control the genomic expression. So it's not an absolute thing, but broadly, slow working hormone will work intracellularly through the nuclear receptor. Fast working will work mainly through the extracellular receptor, the membrane receptor, to work in that perspective. So receptors can be membrane receptor, as I said, and within the membrane, different chemical pathways can be used. The most important and the most common is the G protein coupled receptor. And we'll talk about how they use cyclic AMP, phospholipids, and other things. Then there are ones which look like cytokines. This include growth hormone prolactin, and ones which have got internal receptor action like insulin. So these are the membrane receptor. The nuclear receptors are basically the ones which change the expression of the overall pathway, and these include steroids, thyroxine, and cortisol in that regards. So membrane receptors include the ones which have got G protein coupled ones. So these are basically very interesting proteins. They have got 7 transmembrane domain. They've got external structure and they've got internal structure. So what nature has done in terms of evolution is that these 7 transmembrane are the same. Just by changing the external and the internal structure, you can have huge combination of overall action. And this is the most common form of signaling. I'm not even talking about hormonal signaling, but the way you see the photons, the way you smell, the way the body perceives the number of drugs, it's all through the G protein coupled receptor. So this is the most important way body messages go from that regards. Now this G protein is then linked to a particular alpha, beta, gamma subunit. We won't go into too much detail onto that, which then lead to subsequent signals from that perspective. There is a type 1 cytokine receptor, which basically, as soon as the hormone binds it, comes closer, starts producing hormone action. And then finally, you've got the tyrosine kinase, which has got internal receptors. Now, this kinase aspect is very, very important. Once your hormone binds to the receptor, so hormone is the first messenger. It usually makes some changes which alters the phosphorylation of different compounds. So whenever you talk about all these hormone signaling, we are talking about either this Janus kinase, tyrosine kinase, G protein related kinase. So they usually will change the phosphorylation status of the second messenger, which will then take its message forward. So this phosphorylation, dephosphorylation is the crux in terms of this in that regards. Now, just a few words about G protein coupled receptor. They have got a domain which is outside, which is basically waiting for their hormones to come and act. And then they have got 7 transmembrane, which is then linked via a particular G protein. And this G protein will then stimulate, depending upon the action, it has got this alpha, beta, and gamma unit to decide about how to act. Now, from here, you will act and perceive the effect of photons, odor, calcium, peptides. So it's like one of the most common, 60% of all messaging is happening through the G protein coupled receptor. So it's very, very important clinically from that regards. Now, problems in these receptors. Now, we have been talking about problems in hormone synthesis, problems in hormone transport. There could also be a problem in the hormone receptor. So, if your ACTH, which we discussed earlier, is not going to work because its receptor is not working, you will have features of ACTH deficiency even if the level is high. So, hormone abnormalities can happen because the gland is not there. The gland is not producing the hormone. The hormone is there, it is not being released. It is not being transported. It is not acting. So there are multiple factors at which it can cause a problem in that regards. Now the GPCR signaling means that as soon as your hormone binds to the receptor, the GDP in the alpha subunit changes, it gets phosphorylated. So again, a phosphorus factor into GTP, and this will then dissociate the alpha subunit and you will start producing a lot of cyclic AMP. This is the most common mechanism which acts, and this cyclic AMP will work on that and your beta gamma unit go off. Now this will activate number of pathways. After some time, there is an intrinsic enzyme which will then convert this GTP to GDP. So it doesn't mean that you stimulate, it will keep on working all the time. It will convert to GDP, it will go back, and then it will again bind to beta and gamma, and this will stop the overall process. So this is a self-limiting process when we talk about cyclic process in terms of G protein. Second messengers here, as discussed, include multiple. One is cyclic AMP, which is the most common. The other messengers which are there in this setting include cyclic GMP, calcium, IP3 DAG, and nitric oxide. So these are something which you can go into more detail for individual hormones. Just to remember that binding of a particular hormone will be determined by the external part of the G protein, and the internal part of the G protein will decide which one will be the second messenger. And the same hormone can use multiple second messengers in that perspective. And very importantly, we now know that G protein may also be linked to the nuclear signaling as well. So peptide hormones can also control DNA production, and this is important from a clinical perspective. So there are various hormones which use different pathways which you can go. Now we have discussed about disorders which cause decreased hormone action because the receptor is not working. But suppose the receptor is working a lot, what will happen then? This is a very interesting disorder. The 3-year-old boy presented to us with very early puberty. So he was having changes of puberty which were equivalent to around a 12-year-old boy. So we thought that his testes are producing more hormones, but why were they producing more? The reason was that there was a activating mutation in the receptor which controls the effect of LH which comes from the brain. So because of this activating receptor, the body was producing a lot of testosterone even without a signal. So this is, again, you can have resistance or you can have hypersensitivity to a particular hormone which is there and which can cause a lot of effect in that regards. Now cytokine receptors are classically, the most common is growth hormone receptor. The hormone binds, it proximates the extracellular domain and separates the internal domain, which will then cause production of the kinase, and then you've got the further action which will happen. Now this is what is known as the JAK-STAT pathway. This is common to many other pathways like growth hormone, prolactin, leptin, and you will have multiple action which are going to happen in this situation. Now if this receptor is not working, you will have this. You have this 6-year-old boy who presented to us with growth failure. The height is around 2.5 years. So you can see such severe short stature because the growth hormone is not working. So receptor problems are very, very important from that regards, and this is classically known as Laron syndrome in that regards. Another important receptor is the insulin, which is an intrinsic tyrosine kinase. It does not require external kinase, but essentially pretty similar to the cytokine receptor. So membrane receptors are rapid to act. They use second messengers. They usually cause phosphorylation, dephosphorylation. Rarely will they affect the nucleus. So this is a major factor as far as the receptors, when we talk about membrane receptors, are concerned in that setting, in that regards. What about the nuclear receptor? Now nuclear receptors are common mainly for steroid hormones, and what they do is that they will go and bind to their receptor and go to the nucleus, and it will say, okay, you produce this particular protein, you stop production of this protein. So this is a genomic effect. This is a slow effect, but they are talking about slow processes which are long, and that's how they work on that regards. And from there, they will produce specific proteins. So if you talk about any of these, cortisol in form of testosterone, estrogen, they all act via the nuclear pathways. Many of the vitamins, vitamin D, calcitriol, vitamin A, will act via the same pathway. So this is a intracellular nuclear receptor slow process genomic regulation. There is also some news that there may be an interaction of these hormones on the membrane as well. So there is an overlap, but largely they will act through this pathway. So we have discussed about the action of particular hormone. We'll just close on to this about how is a particular hormone regulated. And for that, I have used this example of the growth hormone IGF-1 axis. Now, if you see, the hypothalamus produces growth hormone releasing hormone, which increases the growth hormone level, which then acts on the liver to produce IGF-1, which causes growth. So this is a long process. Now, what are the ways things are regulated? If you look at it, there would be hormones which are stopping it. So somatostatin and cortisol will suppress growth hormone. There will be hormones which will stimulate it, like thyroxine and insulin. You will also have an effect directly on IGF-1 as well as the receptor. So there are multiple external factors which are regulating. So it's not just your gland, but other hormones which are also regulating. So if you have to look at growth hormone, you have to ensure that the thyroid is normal. If somebody's thyroid is low, the growth hormone will be low. From there, you will have the body fat, which will decide about how the growth hormone is working. So there will be stimulant factors which are there. There would be developmental issues. If the pituitary is not formed, if the somatotrophs are not being formed, how will your growth hormone come in? There would be issues about growth hormone synthesis. If you have a proper synthetic gene, is there or not, your synthesis will not happen. There could be a problem of release. There could be a problem of transport. There could be a problem of receptors. There could be a problem of its second messenger, which is IGF-1. And finally, the growth plate problem. So if you see a child who is short, can have a problem right from hypothalamus to the thyroid, to the adrenal, to the fat, to the growth hormone production, to liver, and to the growth plate. So this gives you the complexity as to how the various hormones act and interact on that perspective. I think this is the last slide, and we'll just close with this one about a very, very important concept in hormones, which is the feedback response. So as we said, the hormone secretion of a particular hormone is regulated by its end effect. So if you are going to regulate thyroid production, like TSH, it is going to be regulated by what is the actual thyroid hormone. And this feedback is very important to understand when we talk about overall interaction. So if your levels are high, the levels should come down of the stimulant factor. Same, if the levels are low, the stimulant should be high. And if you use this 2 into 2 table, you can understand how the discrepancy between the stimulant and the actual hormone level will give you a diagnosis. And you should always look the hormone levels in a particular context. So I think this is what we are going to discuss about. There were a few about perinatal endocrinology, which we'll maybe discuss about subsequently on that. But I think today the key focus was on in terms of what really are hormones, how are the hormones produced, how are they transported, how do they act, and how do they interact. So just to summarize the key learning points, hormones involve a multi-step regulation. Synthesis and release are the key. Some are regulated at synthesis, some at release. There is an important role of binding proteins, particularly for steroids, and receptors. You need to understand which receptors which are acting. But if you understand clearly why is that hormone there, is the hormone there for a quick response? It has to be a peptide. It has to have a short half-life. It has to have an extramembrane receptor. If you want a response for a long-term response, it will usually be a steroid. It will be a slow to produce, slow to work, intracellular receptor, and genomic action. So if you understand that much, your physiology will help you which way you're working for. You can all go and have a look at our website. There are a lot of physiology lectures which are there on different parts of calcium physiology, glucose physiology, electrolyte physiology, which are part of the free preview course. If you enroll into that, you will get a lot of these physiological aspects very, very clear In that regards, there is also other courses and our book as was.
So you have very rightly laid stress on certain aspects, which as students usually they miss, like the binding proteins and the way you correlated them with the clinical scenarios, sir. It was really extremely well, sir. Thank you for the talk, sir.